Good morning, good afternoon. It's 12 noon straight up here on the East Coast. Welcome to Maternal Mental Health Leadership Alliance's webinar on maternal mental health and the impact on the infant. We are so glad that you are here with us today. We know that you could be doing many other things. We know many people are on vacation, so we'll be sharing this webinar, but we're just really grateful to have the opportunity to talk about this really important topic with you today. So welcome. By way of introduction, my name is Adrienne Griffin. I am the Executive Director of Maternal Mental Health Leadership Alliance. And next slide, please. We have two amazing speakers with us today. I'm delighted to introduce Ruthie Arbit, who is a pediatric, perinatal, and infant mental health therapist, and Dr. Lee Johnson III, who is a senior fellow at early childhood education at the Southern Education Foundation. And more importantly, he is an infant mental health specialist and the chair of Maternal Mental Health Leadership Alliance's board of directors. So we're so happy to have these two fabulous speakers with us today, and they will introduce themselves and share more about themselves later in the webinar. Next slide, please. So just a word about Maternal Mental Health Leadership Alliance. For those of you who might be new to us, we are a nonpartisan nonprofit organization leading national efforts to improve maternal mental health in the United States. And we do this with our three strategic pillars. We advocate for change, we build partnerships, and we curate information by hosting events like today's webinar. So again, thank you for being with us. The webinar is being recorded and will be shared with you later. All right, we're going to do a quick poll to find out who is in our audience today. So please go ahead and select which category best describes where you work, how you spend your time in the professional world. So we just gathered this information so we know who's in our audience and we can better target the different programs that we have to fit your needs. All right, we'll give that another second or two. Again, we appreciate all of this information. And we also wanted to share with you that when we announced this webinar, we had more people register for this webinar than any other webinar that we've ever held. We had over 1,500 people register. When we announced it within the first hour, we had about 250 people register. So we're glad to fit the needs of our audience. So really appreciate that. Okay, so let's move on. So just a few housekeeping issues before we get into the important subject matter. At the bottom of the screen, you can use the Q&A button to ask a question. We have plenty of time at the end of the presentation to address your questions. You can also show your captions and your reactions, and we've seen lots of hearts coming up already, so thank you for that. A special thank you to our sponsor, the Irving Harris Foundation. They gave us a generous grant to create not only this webinar, but also a fact sheet on this very topic. Next slide, please. And that we'll be sharing that fact sheet as well. So here's a quick overview of what we're going to be covering today. I'll do just a very brief overview of maternal mental health and then turn it over to our terrific speakers to talk about infant and early childhood mental health, and then share insights and interventions from their clinical perspective. And of course, we always end everything with resources, referrals, and additional training opportunities, and then our Q&A session. So as I mentioned, we have a new fact sheet on this topic, and both Ruthie and Lee have contributed to that fact sheet along with other reviewers. We will be sending a follow-up email that includes the fact sheet as well as the recording from today and additional information. So that keep your eye out for that email coming from us by tomorrow. And as I said, after this email, after this webinar, we will send you an email with a brief survey, the presentation slides, the webinar recording, and the new fact sheet. So as we dive into this, we know that some topics can be challenging, and we encourage you, if you need to take a break. Again, we're recording this so you can come back and watch it at your convenience. Okay, so just a few slides on maternal mental health conditions, just to make sure we're all on the same page. These are mental health conditions that occur during pregnancy and up to 1 year following pregnancy. They are the most common complication of pregnancy and childbirth. They impact 1 in 5 mothers in the general population, and as many as 1 in 3 in high-risk groups such as women of color, parents with a baby in the NICU, military mothers, and others who are in high-risk categories. And we know these conditions include not just depression and anxiety, but also OCD, PTSD, bipolar illness, rare cases of psychosis, and substance use disorders. And so everybody in the vernacular is familiar with the vernacular postpartum depression. What we like to say is it's not just postpartum, it often starts during pregnancy, and it's not just depression. And just a quick look at MMHLA, maternal mental health by the numbers. About 800,000 families each year are impacted in the United States. 22% of maternal deaths are attributed to maternal mental health conditions. In fact, suicide and overdose combined are the leading cause of maternal mortality. We know that the vast majority, as many as 75% of those impacted by maternal mental health conditions, do not receive the care that they need. And this leads to significant cost to our society, about $14 billion each year in untreated maternal mental health conditions just in the United States. So why do we care? Women with untreated maternal mental health conditions are more likely to, during pregnancy in particular, not manage their own health. They may not attend prenatal appointments. They may have poor nutrition. They may use substances such as alcohol, tobacco, and drugs. And they may experience physical, emotional, or sexual abuse at higher rates. For new mothers who have untreated maternal mental health conditions, they may be less responsive to their baby's cues. They may have fewer positive interactions with their baby. They're more likely to experience breastfeeding challenges, as well as question their competence as mothers. And so what is the impact on the child? Children born to mothers with untreated maternal mental health conditions are at higher risk for poor birth outcomes, including low birth weight, preterm birth, longer stays in the NICU. And then when they do come home, they're more likely to have or exhibit excessive crying, perhaps impaired parent-child interactions. And this can lead to long-term behavioral, cognitive, or emotional delays. We also know that untreated mental health conditions in the home can lead to adverse childhood experiences. And so that's really why we're digging into this topic today. What is the impact on the child and what can we do about it? The good news is that maternal mental health conditions are often temporary and treatable. Pregnant and postpartum people are actively engaged in the healthcare system. We don't have to go find them. We know where they are. They're at the obstetrician's office. They're at the pediatrician's office. There's ample opportunity to interact with them and talk about their mental health. We know that mothers, babies, and families can recover because there are evidence-based treatment options that are widely available. And there are more and more resources for both providers and parents on this topic. So at this point, I am now going to turn it over to Dr. Lee Johnson III, the first of our two amazing speakers. So Dr. Johnson, welcome. We're so happy to have you here. Thank you for not only being with us today, but for your leadership as chair of Maternal Mental Health Alliance's board of directors. There we go. Yeah, let me get it out. So please take it away.
Well, good afternoon, everyone. It is such a pleasure to be with all of you. I know that I can see so many hearts from the chat, so I know many of you who are joining, who I've known just for a little while, and many of whom I'm sure I've known for many years. As Adrian has shared, my name is Dr. Lee Johnson III. I serve as a senior fellow for early childhood education at the Southern Education Foundation, where I lead our Southern Early Childhood Education Justice Network, which is a regional initiative that unites state and national partners to improve early learning opportunities across the South. I also have the privilege, as Adrian has shared, of serving as the board chair for the Maternal Mental Health Leadership Alliance. But before the titles and the policy tables, as you can see on the slide, I come to this work as a son. My mother, who was a deeply caring nurse, navigated her postpartum years at a time when maternal mental health wasn't named and supported or prioritized in the ways that it should have been. And like many women of her time, she carried emotions quietly, making the move from Alabama to California on her own in pursuit of a better life and a career in nursing. So this was a time when her mental health experiences for her were often misunderstood, often minimized, and maybe perhaps left unspoken. without the tools and the language and the systems of care that we know now today that are so vital. So I recognize that she may not have had the full words to describe what she was feeling at the time or the support to process it. And I recognize that since her passing, both her presence and her absence have shaped me ever since. So I'm very fortunate to honor her legacy in my leadership with the board. And I see um, this work as part of my life's work to ensure that other mothers have what mine did not, which was quite frankly that support and that connection in the systems that meet their needs with dignity. So I just want to thank Adrian again for this opportunity and turn it over to my wonderful friend who I now have met, Ruthie, to share a little bit about herself as well.
Thank you so much. I love all these little hearts. They're so cute. So my name is Ruthie Arbit. I am a perinatal and pediatric therapist. I run a group practice here in the DC, and then I also work at MedStar Georgetown in our mother-baby intensive outpatient program that I will tell you about later. I came to this work. I am a mom of four, and I experienced a traumatic birth and complicated postpartum period after my oldest was born. And so I think I actually was working in this field before having my own children. And now I live and breathe maternal mental health. And I am so appreciative of all the work that MMHLA does and PSI. And I really appreciate that this is something that's not in the shadows the way it was 11 years ago and 20 years ago and 30 years ago. So I'm really honored to be here.
Thank you, Ruthie and Lee. It's really just a delight to have both of you with us, and it's been really wonderful working on preparing for this over the last couple of weeks. So we're so eager to hear what you have to say. So Lee is going to start with talking about the intersection of maternal mental health and infant and early childhood mental health. So passing it over to you, Lee.
Yes. So, when I shared that opening slide, my professional journey has always lived at the intersection of relationships and systems, whether it was directing home visiting programs, whether it was building Alabama's first infant mental health association with partners, or advocating in state and federal spaces. Um, I am simply someone, here to help create the kind of world that, as I said, shared before, a world where I wish my mother could have lived in and one that every child and caregiver deserves. Um, so I do want to speak to that very intersection, the shared space between maternal mental health and infant and early childhood mental health. Because while we often talk about these topics separately, they are braided together, influencing one another in every moment of care, in every moment of regulation, in every moment of connection. So let's start by naming what infant and early childhood mental health, or IECMH, is not. As you can see from the comic on the slide, I get a kick out of seeing this, but it's not about diagnosing babies with disorders or labeling, clinical dysfunction, right? Yeah, as you can see from the comic, it says, I wish I'd started therapy at your age, right? But I don't mean that diagnosis never happened. I mean that the field itself is rooted in something deeper than classification. It is about relationships. It is about how children experience safety, connection, and regulation in their earliest years. It's about supporting those relationships and not labeling them. So we're not pathologizing infancy. Instead, we're shifting the frame to see behavior as communication and relationships as the soil in which development grows. Next slide, please. And so when we think about what infant and early childhood mental health is, or IECMH is, it is the developing capacity of children from birth to 5 to experience and regulate and express their emotions, to form secure relationships and explore and learn within safe, nurturing environments. And so when you look at this, I want to encourage you to not see this as a checklist, rather to see this as a lens. It's how we understand the emotional and relational world of children in their earliest years. And those early years matter deeply because the quality of a child's relationship literally shapes their brain architecture. A child's first classroom, as I often say, is the lap of a trusted adult. And what happens in that space, emotionally, physically, has a lifelong impact. Next slide, please. And so, to fully appreciate where we are now, I would invite us to have a look at where we've been. As early as the 1930s, researchers were documenting emotional disturbances in infants, and it was often through a deficit lens. Terms like infantile and hospitalism focused on behaviors without acknowledging relational context. Renee Spitz studied infants who were physically cared for, but oftentimes emotionally abandoned in institutions. And he found that they declined developmentally in alarming ways. In the decades that followed, figures like John Bowlby, Eric Erickson, Mary Ainsworth, Selma Freiberg, for those of you who have heard their names through early care and education courses, understand that infants need more than nutrition and shelter. They need attunement, they need trust, and that trust begins with a caregiver. In the 1980s and 90s, we see T. Barry Brazelton's touch points and also the founding of 0 to 3, where I worked on infant and early childhood mental health on a federal level. And that really helped professionalize and expand our understanding of IECMH as a developmental and not pathological field. And still, while infant mental health evolved in one direction, maternal mental health was fighting to be seen at all. Historically, maternal mental health and emotional needs were often ignored, as you can see from the timeline, often stigmatized, treated as moral failings. Conditions were labeled and support systems were practically non-existent. It wasn't until the 1980s that the postpartum depression even entered the mainstream clinical conversation, largely due to the Edinburgh postnatal depression scale. But we know that access to care remained limited, especially for women of color, mothers not earning a living wage, those families that are non-English speaking or where English is not their primary language spoken in the home. And so by the 2000s, we began to understand maternal mental health in a fuller way with the framework of perinatal mood and anxiety disorders. So today, when we think about maternal mental health, it's more so characterized as a mother's emotional, psychological well-being during pregnancy and postpartum, including her capacity to cope, connect, and care. So the research is clear. Maternal well-being shapes child well-being. These are not parallel conversations. They are one. All right, next slide. So why this matters now more than ever. Um, when in preparation for this webinar, thinking about talking to this point of why this matters now more than ever, we should care. As I often say, that childhood is not an adventure we choose, but it is chosen by adults familiar and forever unknown through the experiences they create for us. And it is also important for us to care because the mental health of the parent and child are braided together. Why? Because learning begins in utero, because the first 3 years are the most critical window of brain development, because healthy development depends on safe, stable, nurturing relationships with highly engaged adults. But we're also in a moment of real policy threat. The FY26 federal budget process, as we all know, is proposing to eliminate the Infant and Early Childhood Mental Health Grant Program, We know that other institutions, much like the CDC, are undergoing restructuring in ways that reduce maternal mental health leadership roles. Funding for maternal screening is becoming unstable. And yet, in our communities, especially across the South, where much of my work is rooted, we see the opposite. We see the resilience, we see the creativity, and we see the brilliance from doulas, from grandmothers, from early educators and care workers, and from folks like you. And so our systems must begin to catch up to that wisdom already living in our communities. So I will
Uh,
turn things over.
Thank you so much, Lee, for setting the stage for what infant and early childhood mental health is and what it is not. And that is so directly linked to the mental health and well-being of the caregiver. And one thing that I want to point out is, if the mom's not doing well and is not able to provide the infant what he or she might need, that other caregivers can, right? They can step in, that there are other adults who can fill that need. And I just wanted to give you the opportunity to just talk about that for a second. Oops, you're still on mute.
Yes, absolutely. I think it is important for us to remember that in the context of relationships, children navigate the world, right? It is where they understand the beauty of ordinary magic that happens, whether that happens in a parent's gaze, whether that happens in a caregiver's voice, in those early moments of shared attention. I think one of the simplest and most powerful things that any caregiver can do is look into their child's eyes. As I often say, your eyes are your child's Disneyland. The wonder, the joy, the safety of being seen, that's where the foundation of emotional security is built. So, yes, I would just plus one that uh, we all have folks who have loved us into being. And in these cases where it may be a grandmother or an aunt, they are contributing to that emotional security being built for that young one.
Right. And I say that and I raise this in part because, we hear over and over again from women who may have experienced maternal mental health conditions that they didn't feel like they bonded with their baby, that they weren't a good enough mother. And we want to reassure them that it's okay, that others can step in and
Yeah.
create those necessary moments of attachment. And so as you pointed out, in that maternal mental health history, right, there was a lot of mom blaming that was going on for a while. And we want to make sure that we're removing that in the course of this conversation.
Yes, and just to reiterate, these kinds of serve and return, as they are called from an early childhood perspective. These interactions happen between any consistent, loving caregiver,
Yeah,
whether that is a father, whether that is a grandmother, an aunt, a foster parent, a family friend, because the child's brain doesn't ask who you are. They are wondering, are you attuned to me? Do you see me? Do you return my gaze? And those interactions don't just benefit the baby; they benefit the caregiver too. Uh,
absolutely.
so yeah,
Absolutely. Yep. And we're going to hear about some of that from Ruthie, because this is really her area of expertise, sort of the dyadic interventions and how we know that the mom is most often the primary caregiver. And so we're going to focus on that aspect of things as we turn it over to Ruthie.
Thanks. I think maybe we want to go to the next slide, please. Yeah. So as Lee just framed everything so beautifully and thinking about the maternal mental health and the infant mental health, it's so interesting how over time these things were separate. And I know as I'm a therapist and I know other therapists that say, I'll work with parents will say, can I bring my baby to session? And there are some therapists that say, actually, I find the baby or the baby's crying or the baby needing to eat or be changed distracting. So I would prefer you come alone to session. And so it's just really interesting to think about how even in the mental health field, maternal mental health and infant mental health have sort of been siloed. And it's only recently that we're trying to shift the clinical lens and think about how these things can't be siloed. That doesn't exist, right? There is no, when a mom is suffering from depression or anxiety or OCD, most often that's within the context of what's happening with the baby. So the OCD is around harm to the baby or keeping the baby, making sure that there are no contaminants so that the baby doesn't get sick, right? It's rare that it's a mom with postpartum OCD and she's only thinking about herself. So we can't treat the maternal mental health without thinking about what's happening here in terms of your own conception of yourself as a mother, your matrescence, right? Like, how are you falling into this new role of motherhood? So when we think about this slide, the big problem here that we see is that moms are unwell, and that is impacting the baby, and it's impacting their own self-conception. And I would actually add, so here we say it's impacting the baby, impacting the dyad, impacting the child later in life, and it's really impacting the family system. And we see how partners and non-birthing parents and grandparents, all of these are impacted. If your baby is in daycare and there's a parent that is having an untreated maternal mental health crisis, that's going to impact the rest of the classroom. It's going to impact their peers, right? We exist within this interpersonal web of relationships, and all of those are going to be impacted if there's one person that's unwell. Next slide, please. So a little bit about some of the specifics that we see. So we know that when moms are depressed or they're having traumatic experiences, sometimes they can be a little more withdrawn. I worked with a mom who felt like she couldn't even be on the same floor as her babies because she didn't want to hear them crying. She didn't want to hear the noises that they were making. Sometimes, and this is one of the things that can be a little bit hard when you're thinking about doing treatment in a group setting, sometimes it can be the opposite spectrum. So you can actually have moms, I'm thinking in particular about some of the moms that have OCD, and they don't feel like they can be away from their baby for 5 minutes. They're constantly checking, constantly attuned in a hyper vigilant way. So you have both sides of the spectrum, right? So moms that are a little more withdrawn and not checking in, and then moms that are constantly checking in. And what is the impact of this, right? It means that if your brain is on hyperdrive and you're thinking about every single second, every time your baby's moving and is your baby breathing, then that's going to be less time that you have to enjoy your baby or attune to your baby or smile at your baby or even co-regulate, right? Just being present and being calm and watching and waiting and wondering what's happening with my baby right now. If your brain is too checked in or too checked out, it's going to make these interactions a lot more difficult and they're going to be a lot more seldom. And it's interesting. I know that we've been talking a lot about how the maternal mental health impacts the infant mental health. And I would also argue that this is a bidirectional. It goes both ways. Maybe you have a mom that's feeling well, and it's an infant that's medically compromised, or it's a baby that had been in the NICU, or it's a baby that has colic or sleep difficulties, or it's a baby that just has a different type of temperament. All of that is also going to impact the mom, right? So the mom is feeling what the baby's feeling, and the baby's feeling what the mom is feeling. This is an interconnected web. These two things are not separated. Next slide, please, Mia. Thank you. So in the short term, what are the impacts of the child if you have a parent with untreated maternal mental health disorder? So an infant might be more fussy. They might be less responsive. They might be inactive. There might be elevated stress hormones. And we know that there's a lot of long-term impacts as well. We know that there are conduct issues, and there's some studies indicating issues like ADHD or behavioral issues later on in life, right? So there's a lot of stuff that can happen in the short term and the long term. Next slide, please. So the good news, so similar to what Adrian was saying, I just really want this to be like strengths-based and positive. So the good news is that there's a lot that we can do to change this. So if the system, if the family system between parent and child is not in a great place, there are things that we can do, right? And this is not your fault. If someone offered you the choice, would you like to have maternal mental health issues or not? I think you would find very few people that would say, sure, I would love to have that, right? So this is not your fault. And there are those of us that are trained in this and we can help you. Next slide, please. So I think this is in relation to a specific question, Adrian, right?
Right. So just curious, Ruthie, like what have you seen over the last 5 to 7 years? And what interventions are you seeing, or what kinds of programs like your IOP to address these issues? Yeah.
Yeah. So I think, you know, what I wrote here, which it sounds a little bit dramatic, but I wrote down that people are suffering, right? I think that this is today's day and age. It's hard to be a human. It's hard to be an adult. It's hard to be a child. It's hard to parent. There's a lot of, you know, we're parenting in silos versus parenting within a village and in a really strong family support system, the way that people parented for many, many generations. So this is a new thing that's happening. I think from a therapy perspective, it used to be 10 years ago that when a parent would come and say, you know, I have a 6-year-old and my 6-year-old has anxiety. Can you treat my 6-year-old for anxiety? And we would say, sure, of course, bring in your child. Now parents are coming in and they know my 6-year-old has anxiety. Can you treat my child? And I need some parent support. And we know that there's a lot of parenting work that has to happen for the mental health to change. So this is a shift that's happening in the infant and maternal mental health field, but I would argue that this is a shift that's also happening in the pediatric and adolescent mental health field as well. So we know that parents and what's happening at home is an integral part of the mental health piece.
Yeah,
That
absolutely.
Yeah.
Absolutely. I'm just kind of scrolling through the questions as you've been talking, Ruthie, and somebody asked about what is elevated stress hormones. Could you talk a minute about that?
Yeah, that's sort of like what's happening in your brain, the neurochemistry, right? What are the different neurochemicals that are firing in certain situations? So we know that there's a stress response, which is cortisol. We know that for babies, we actually now it's really amazing. Now that we have fMRIs, we can actually see that even a newborn inside a womb, if a mom is exposed to domestic violence, that newborn that's growing inside her stomach has elevated cortisol levels. So we know starting in the prenatal period, newborn infants, embryos can experience stress. And we know that this happens in the postpartum period too. So if a mom is stressed, the baby's going to be picking up on some of those stress hormones. It's not that stress is contagious, but it's that we humans exist in this in relational webs. And so just like if you were an adult, right? If your partner was suffering and super stressed about something that was happening at work, you would be somewhat stressed as well, right? Like that makes perfect sense.
Yeah, yeah. Thank you. Thank you. Okay, so can you share with us some interventions that you use or that have been successful in addressing the mother-infant dyad?
Absolutely. I think it's the next slide there, Mia. Yeah, so some of I was just wondering if this was Lee's slide or my slide. I think this is mine.
Yeah, go ahead.
Yeah. So it's interesting. One of the ways, by the way, I loved how Lee framed infant mental health. And I would say one of the ways that I sometimes explain this to the moms that I'm working with, and, you know, obviously note that like these moms are not necessarily infant or early childhood therapists or specialists, right? So one of the layman's terms that I use to describe infant mental health is like, imagine you take a 1-year-old to the playground and, you know, first you bring the 1-year-old there and they're holding on to you. And then you sort of let go of their hand and they get to choose, do I walk over to the sandbox or do I stay here close to mom? And then let's say they feel safe and they feel comfortable and they putter over to the sandbox and they say, what is this? What is this material? Do I explore this or do I not explore this? And let's say they enter the sandbox and there's someone else playing with the toy. Do they wait their turn? Do they walk over? Do they walk over and take their turn? Let's say they all of a sudden start playing with a shovel and the other kid grabs the shovel and then they have all these feelings of, oh, I'm really frustrated. I was playing with that toy. Or I'm really angry. Why did you take that toy? Or I'm really scared. That person is taking my stuff and I don't know what to do. Do I look back at mom and say, Mom, how do I handle this? Right? These are all ways, like playground readiness is basically what needs to happen from birth to age 1 for a child to be, independent, but also regulate those emotions that come with human experience. Regulate that, am I ready to explore? Do I need to stay close? Am I ready to make a friend? Am I ready to touch something new? Right? That's like a little bit of another way to think about infant mental health. So how do we help that? So let's say you have a mom that comes to, let's say we have a mom in our IOP, our intensive outpatient program. So that means an intensive outpatient program means, someone that once a week outpatient therapy isn't going to be enough for them. Instead of just 45 minutes or 1 hour, they really need 9 or 10 hours. So they don't need to be in the hospital. They're not that acute, but they also need more than just once a week. And so how do we manage when we have moms in our program that are saying, it's hard for me. We had one day in our program, we were doing like a little game where we were putting like different sensory materials into a plastic bottle. And one mom started sobbing and said, I don't know what my kid likes. I've never played with my child. I'm not there yet. Right. So how do we build this capacity if you have a mom who's really struggling? So some of the things that we do are, I have a couple more slides with really, really specific information, but dyadic interventions are parent-child interventions that are really focused on how do we help you connect with your baby? How do we help you feel good about your interactions? How do we want moms to feel competent and confident. So, if you have a mom that's maybe she's in a hospital program or she's in an IOP and the baby's not there, the mom feels great. But then when she goes home and then the baby is there, she doesn't know what to do. And she's back in that loop of, I'm not doing a good enough job, or I don't know how to care for my baby, or my baby's crying because my baby doesn't like me, or my baby's crying and I don't know what to do because I don't know who this person is. This person just showed up in my life. I don't know who they are or what they need or why they're screaming all day long. So dyadic interventions are really focused on that relationship between the two. Next slide, please. So there's a lot of different types of interventions out there, which is amazing. Most of these have a strong evidence base, so you can look them up. We have on the last page, we have resources to a couple of the different ones. The main dyadic interventions that we use in our IOP are circle of security. And then this other intervention that we created, it was a group of 4 of us clinicians. One was a psychiatrist, one was a psychologist, and 2 of us were infant mental health therapists. And we created our own intervention that's a little bit of We Play Denver, and then a little bit of baby cues, touch points, reflective parenting, circle of security. So we just sort of cobbled together different interventions, and our idea was to have 1 week the session would be more focused on like, how do I play and interact and watch and wait as my baby's sitting here and I want to play with my baby. And then 1 week was more reflective and like, what is your baby trying to tell you when they're crying? What does that mean? So there's a lot of different types. Yeah. Next.
Right. I know you're going to talk about the circle of security, right? Because we've talked about this a lot in getting ready for this. So go ahead, because then I want to talk about what I used to see in support groups that I used to lead. So
yeah. Would you like to go first, Adrienne, and I can say that after?
Sure. So, for many years, most of I had postpartum depression and anxiety and came to this work initially as a volunteer with Postpartum Support International. And one of the things I did was lead support groups for new moms at our local hospital. And, moms would be in the room, and we always encourage them to bring their baby, of course. We also said, hey, if you don't want to bring your baby and you want a little time off, that's great too, whatever works for you. But moms would be in the room, and as everybody does when they're holding a baby, right? They're rocking back and forth, and they're, nestling the baby in. And at the same time, they're saying, I'm such a bad mom. I don't know how to take care of my baby. And everybody in the room would be like, wait a second, look, you're doing it. You're doing a good job. You're doing great. And then you could just see her almost like physically change, be like, oh, hey, you're right. I am doing a good job. Right. So he had these very like it, and I didn't know anything about circle of security, but what I did see was sort of this positive feedback loop that would happen, right? When we would say to a mom, hey, you're doing a great job. You are the best mom for your baby. Like you could, they would almost change physically. So why don't you talk about like the theory behind it now? Yeah.
Yeah, absolutely. Happy to, Adrian. And I will also say, like, I've been that mom at Target where your kid is having a tantrum.
Oh, yeah.
Or I was recently getting off an airplane and this person just looked at me and she's like, you did a great job. And I was like, my kids were screaming, right? They were all screaming and tantruming at this point, but she was like, you're doing it. And that's what we need. We need
Yeah.
more of people just being like, great job, mom.
Yeah.
Like, I see
Yeah.
you out walking your baby with a stroller, you're doing great.
Yeah.
Your kid is having a tantrum, you're doing great. Like I know your kid just pulled down his pants in public and you are really, really embarrassed, but you're doing great, right? Like
Yeah.
we just
Yeah.
really need
No mom shaming, right? We got to
exactly,
uplift moms.
exactly.
Absolutely.
Yeah, because we're all trying our best, right? Like I really believe that we are all trying our best.
Yeah.
Okay, so a little bit about circle security, and I'll also talk about how we adapt it. So circle security is this concept that we're all hardwired to want safety and security, and babies will go off and explore the world, and they will go off and learn all the things that they need to learn if they have that safe and secure base. So you need that safety and security in order to go out and learn and develop. And it's interesting because the way that we talk about it in our group, we have moms that maybe they were adopted or they had really traumatic childhood experiences. And this idea can feel really hard for them, thinking about their own childhood and what they missed. So we talk about what are the ways in which maybe it was a teacher that provided you safety and security and that allowed you to learn. Maybe it was a sister or a cousin or a friend, but maybe it's a pet. I really talk about circle security with a pet. And I say, what are the ways that you experience security in this world? And then how can we create that for your child? So there's a component of reflective parenting, thinking about how was I parented and how is that impacting my relationship with my child? And then there's also a component of thinking about, yeah, what are the things that bring me safety and security and how can I create that so that my child can thrive? Next slide. Yeah, so here are some specifics. So, Adrian, what you were saying, right? Like, look at how you're holding her, right? Look at how, a mom will have a baby that's screaming and she'll reposition the baby. And I'm like, look at that. Like, you were problem solving there. You noticed I'm holding my baby this way and they're still crying. So let me reposition them. Maybe they didn't stop crying, but you're still attuning to what are they trying to tell me? What are their needs? And then this is what we were talking about, right? Like in the reflective piece, like what was your childhood like? We have this term like ghosts or angels in the nursery from Selma Freiberg, right? Like when you're with your baby in the nursery, what's coming up for you from your past? What's triggering you? Next slide, please. And then there's some even more basic ones, right? Like let's say you have a mom who says, it's really hard for me to hold my baby or attach to my baby. You can just say, where did you choose your baby's name from? Who does your baby look like? Where do they get their ears from? Just getting a parent to even notice what their baby looks like. So yeah, and then there's obviously ways to create attunement, right? Like, what do you think your baby's crying right now? What are some things that you think that they need, right? Do you think are they tired? Are they scared? They're making that scowling face. I wonder what they're thinking. So these are all ways that we can create attachment and attunement in different settings. Like you could do this in a pediatrician's office. You could do this in an outpatient setting. You could do this in your therapy sessions. Exciting.
Love this. This. So we're going to actually go to some Q&A first, and then we're going to come and tie up with sort of what gives you both hope. So we've gotten some fabulous questions in the Q&A. Particularly, there's been a couple of questions about paternal mental health. And so curious, Lee, if you want to take that on. We know that mom's mental health can also impact the dad. We know that maternal depression is the #1 predictor of paternal depression. And so I see you nodding, so give you the
Yeah.
opportunity. Yeah.
Sure, sure. So I will say this is such an important question, um, because I know for the person who probably is asking this, and I've seen this question being asked when I was the maternal infant and early childhood home visiting director in Alabama, we often talked about paternal mental health as well. And so we know, as you shared, Adrian, that paternal mental health does impact infant mental health. Just as I mentioned in the beginning around framing, like with mothers, father figures play a vital role in shaping a child's sense of safety, of regulation and connection as well. We also know that when a father is struggling, we know that it can influence how responsive and attuned they can be. So as you said in your point initially about how there is research that demonstrates the relationships around depression and in the postpartum period. Um, we also know that in many cases, sometimes the support systems are limited for dads. But we also know that the hopeful part is that when fathers are engaged and that when they are present, um, that children benefit across the board. We see stronger attachment, we see better language development, we even see improved maternal mental health outcomes. Just in the ways that we talk about maternal co-regulation, we talk about the co-regulation with fathers too, because their presence matters just as deeply.
Absolutely. Absolutely. And what we often, I remember also telling moms is as long as one parent's doing well, right? They carry the other one for a while and then the other one gets better, right? And as long as there's one parent who's doing well and interacting with the baby and kind of keeping things going, we're in good shape, right? And I see Ruthie nodding on this. Yeah.
And
Yeah.
it could even be the village, right? It could be a
Yeah.
grandparent or an
Right.
aunt or cousin, right? Like it
Right.
doesn't have to fall on one parent.
Right. Right. One of the things that we talked about in preparing for this webinar was the still face experiment, which shows what happens when a mom becomes out of tune or with her child. And because of the timing for this, we didn't have the opportunity to show it. But there was a question that made me ask about this. Hang on one second, because there was a reason that I brought this up. Oh, now I forgot. I'm sorry.
I think it was the technology.
Yes, right. And yes, right. Thank you, Lee. If you wouldn't mind taking that, because it's something that we talked about, right? That technology can contribute to
Yeah.
that same kind of thing. Go ahead.
Yeah, I mean, so we are living, all of us, in an age where technology is woven into nearly every aspect of our daily lives, including caregiving, whether it's, work emails and ordering diapers at the same time or
Right,
looking
right.
at parenting tips. So, so much of parenting now happens with a phone in our hand,
Yes.
and the baby in the other. And so I would encourage us to start with empathy. Parents today are under extraordinary stress, and many of them are doing their best in systems that oftentimes are stretched themselves. That said, what we know from the science of early childhood development is that children are incredibly attuned to faces, especially the emotional feedback that they receive from their caregivers. And again, to your point, the powerful example of the sterile face experiment, which some of you may be familiar with, where essentially in that experiment, the parent interacts joyfully with their infant and then suddenly holds a blank expression for a short period of time. And so then the infant, even as young as a few months old, might show signs of distress. They might be a little confused, like, is mommy playing a game with me? And oftentimes it might express itself as disconnection. But I want to be clear that this is not about shaming anyone because we all look at our phones, we all get distracted. The concern arises when moments of disconnection become the norm rather than the exception. So we know that what we I've heard from colleagues is like what we call good enough attunement, or this concept where it doesn't have to be perfect because it's not about perfection, it's about your presence.
Right, right. I'm going to answer one of the questions in the chat that asked, are there additional supports or information for stressed single parents that may not have a supportive co-parent or village? We often get this question and we talk about, how to, think more broadly. Who is in your faith community, right? Who can you meet moms at the playground or the library, right? Fortunately, now I'm going to use technology in a positive way. There's lots of online platforms that can help moms get connected with other moms or with a therapist. And so if you don't have that supportive in-person village, there's a way to cultivate this. And Ruthie or Lee, do you want to add any more onto that one?
Yeah, I think I agree. There's now a lot of online communities or meetup groups or things like that, and finding a village. Like, I think, yeah, sometimes there's like Single Moms by Choice Facebook group and things like that. So finding your village where you can support each other.
And I know Lee, this is a question for you, Lee. Somebody asked about putting these kinds of programs in home visiting and in other venues, not just in a therapeutic setting.
Yeah, I mean, I think the beautiful thing about home visiting is, we often would say is that the parent is the child's first and best teacher. It is an opportunity for that parent educator, as we often call, synonymous with home visitor, synonymous with home educator, who comes in and models to that parent. So in many ways, it sort of serves as a bridge to the previous question about, for those families who may not be single mothers by choice, who may be navigating building their village or their chosen village. Oftentimes, those home visitors come alongside those parents and equip them with skills so that they can know, recognize, and understand the importance of relationships, the importance of child development, and also gives them an opportunity to display, their love with their little one in real practical ways. I would hear parents all the time, engaged in the trainings that the parent educators are like, I don't want to just be the director. Let me sit in a training and see, like, what are the parent educators learning? I want to build my understanding as well, not just fund these kinds of programs. And I see that, these kinds of experiences of love with their child makes the difference. It makes a difference. So yes, I would say we see it in home visiting. It's supported in home visiting. Home visiting, a lot of people don't often know that it is also a great place to find referrals. So oftentimes home visitors will connect parents with other kinds of supports as well. And so that is something that has always been tried and true in the home visiting field.
Yeah, thank you. I'm scrolling through all the questions and, unfortunately, we never get the opportunity to answer all of them. We'll follow up in writing with some of these. But one I do want to take on is something that Emma put in there about speaking about the best approach about the impact of introducing medication, mental health medication. And the timing on this is perfect. Last week, the FDA did an expert panel on the use of selective serotonin reuptake inhibitors, SSRIs, which is a class of antidepressant medication, on the impact during pregnancy and postpartum. And a couple of key talking points. Number one, untreated maternal mental health conditions actually have a negative impact on the infant as well. There are medications that are safe and effective to use during pregnancy and postpartum. And the conversation about whether to stay on your medication or go off your medication or even start a medication during pregnancy and postpartum is really between the provider and the patient, right? But it is a risk conversation. There is no risk of not treating the medication, as I laid out earlier, right? Moms don't care for themselves. It has impact on the infant. So it is a conversation that each mom, each parent needs to have with their provider. But there are safe and effective medications proven over and over again that you can take during pregnancy and postpartum to address mental health. We would never tell, I'm getting a little passionate, can you tell? We would never tell a mom you need to go off your epileptic medication or your heart medication or your thyroid medication. But for some reason, the world at large, thinks that mental health is optional. It is not. It is every bit as important as your physical health. Now, I'm not trying to be a pill pusher at all. What I'm trying to say is that there is no reason to immediately go off your medication if you're thinking about becoming pregnant or if you are pregnant. It's a nuanced conversation that needs to happen. Caring for the mom is every bit as important as caring for the developing infant. So MMHLA put out a statement with the same kinds of things. I see lots of people clapping on this. Yeah, that SSRI panel really did not do us much help. We've spent a long time trying to educate both providers and patients that it is okay to stay on your medication. So we'll try to answer the rest of the questions either in the chat. I know Mara's been chipping away at it, but we'll also try to answer those either online or in newsletters or whatever. We do want to take a couple of minutes. First, let's launch the poll, right? We have a poll to get your immediate feedback on today's session. And while Mia is getting set to do that, did you find this webinar helpful? Just a quick yes, somewhat, or no. And Mia, if you wouldn't mind bringing the slides back up, we have one last question for both Ruthie and Lee, and that is, what gives you hope now? We've talked a little, yeah, so I'll just, I think we're going to start with Lee for this one. What gives you hope?
Yeah, no, I love this question, first of all, and this has been an extraordinary opportunity to share a little bit about my love for this field, my love for being able to provide support for people who want to know more about the intersection of maternal mental health and infant and early childhood mental health. So I would say what gives me hope is knowing so many people know that this matters. The conversation has changed. When I look at that timeline, I it humbles me, and it also reminds me of how far we've come. People are naming this need and they are acting on it. I am going to be that board chair and say, and MMHLA is acting on it. We see parents and providers stepping into their power. I see cross-sector collaboration. I see people like Ruthie sharing their knowledge and sharing their strategies and coming together in ways that we've needed for a very long time. So it's about, for me, what gives me hope is that we're showing up with intention and care, and that's what brings us together today.
Thank you, Dr. Johnson. And Ruthie, how about you? What gives you hope?
Yeah, I think it's the next slide there, Mia. I think love. I know that sounds a little bit corny, but I really do think that yeah, I think parental love, even when you're really depressed and don't feel it, I think that there's ways that we can sort of dig it out. And then I think that healing is possible. Like some the moms that we've worked with from when they first came in to when they left 12 weeks later, it's an astounding, life-changing difference. So hope is possible and healing is possible. And then one of the things that I love most about doing this work in a group format is how the moms support each other. And they feel less alone and they feel less guilty, and they just you know, they bolster each other, and there's just so much kindness and understanding. And I think that peer model
Mhm.
and that group model is so
So,
powerful.
so important. Again, I remember leading these support groups and women who would come back 2 or 3 weeks later, they had started sleeping more. Maybe they started an antidepressant medication. Maybe they got a doula, whatever. They would come back and they were like a different person. And everybody would say, wow, look at you. And yeah. So of course, we always want to end with resources and additional information. Of course, I'm guessing most of you on here know about the National Maternal Mental Health Hotline, 1-833-TLC-MAMA. Please share this information widely. The hotline has helped over 70,000 families, and it's a great way for moms to make that first step in getting the help that they need. Next slide. We also will be sharing, again, all of this with resources, referrals, and trainings, all kinds of resources specifically around infant and early childhood mental health. Of course, Postpartum Support International is always the go-to resource for moms who need help. PSI provides support, interventions, online support groups, peer mentors, all kinds of things. So always Postpartum Support International is a great place to go. Next slide. And we are at the end of our time. We are, again, so appreciative of you being with us today. Look for the email coming out tomorrow to you that will include the recording, it will include the slides, and it will include our new fact sheet on maternal mental health and the impact on the infant. So again, thank you to our great presenters today, and to all of you, and to our funders, again, the Irving Harris Foundation, and to my team at MMHLA, Mia Hempstead, and Mara Child, who've been on the call making everything happen. Thank you. Thank you. Have a great rest of the day.